I had been having headaches and they got worse. And so I went to the emergency room and found out I had a large mass in my brain.
Cancer is an abnormal growth of cells that will either grow locally or spread to another part of the body. And when you have that abnormal growth of cells, it can crowd out other normal, healthy parts of the body. Radiation is a cornerstone of the treatment of cancer. When we think about the tools that we have to fight cancer, we think about surgery, treatment that will affect the entire body, such as chemotherapy or targeted therapy, and now potentially immunotherapy. Radiation has a more local effect. Radiation therapy is complementary to surgery in the sense that radiation helps treat the microscopic disease that may be left behind. Look in here, how many fingers? Brain cancer is one of the most common conditions that we treat in oncology. A primary brain tumor is a tumor that begins inside of the brain or potentially inside of the spinal cord. The secondary tumor is a cancer that has started in another part of the body and spread to the brain or to the spinal cord. External beam radiation is generally used to treat larger tumors or potentially tumors that are in multiple locations, while stereotactic radiosurgery will be used for generally small volumes of tumors, especially if they're located close to a critical structure in the brain. Proton therapy is a different form of external beam that travels only to a fixed distance inside of the body and doesn't exit the other side of the brain. The radiation oncologist will talk with you about the different forms of radiation and which one is best for your care.
I didn't ask for this to happen, but it's allowed me to learn to appreciate my friends and family in a way that I never had before.
Hey everyone, thank you so much for joining us tonight. We are here with Ask a Radiation Oncologist to help answer any questions there are about brain tumors and brain cancers and cancers of the spine as well. So we're hoping that tonight you find this very useful and informative and a great way to get some of those questions answered that you may have regarding treatment, either for your friends or family members or other people that you may have concerns for. So tonight I am here with a very well qualified panel of experts who will help us address some of these questions. I would like to introduce Dr. Hallis from University of Washington, as well as Dr. Stockham from Mayo Clinic and Dr. Yoboa from MD Anderson Cancer Center. And so without further ado, let's get started. And this is important, at least for us to address a few common disclaimers with these presentations. We're going to do our best to answer any of your questions to the best of our ability and provide as much information as possible, but it's always important to discuss your specific situation with your personal radiation oncologist who can tailor their answers to your concerns and specifically your particular situation. And for further resources that are available after the presentation, you can go to our website, RTAnswers.org, which will provide additional information about different types of cancers beyond just the brain and spine cancers that we'll be talking about today. This is an excellent resource, not only for the basics about what we're going to discuss, but provides access to different support groups and different agencies that can help provide as much information as needed and get you connected to people who can help. Okay, so first we'd like to get started talking about the different types of brain and spine cancers.
When we think about brain and spine cancers, we tend to think about them in terms of cancers or growths inside of the brain. and cancers and growths inside of the spine or spinal cord. And when we think about brain tumors, we refer to them as either primary brain tumors, or as you'll see later on in the presentation, as secondary, or tumors that have spread to the brain. So as far as primary brain tumors go, a primary brain tumor is a tumor that starts in the brain. So it did not start somewhere else and travel to the brain. It originated in the brain. And actually the most common type of primary brain tumor is a tumor or a growth that's non-cancerous involving the lining of the brain. It's called a meningioma. And that's actually the most common type of tumor inside of the skull, or what we call the calvarium, inside of the bone. And then as far as types of tumors that start inside the brain itself, we consider those as far as low grade or high grade. And there's much additional detail that your physician will review with you, but they're generally considered low grade tumors if they're growing slowly. They oftentimes may present with seizures or other symptoms that are specific to the area that's involved by the tumor. A low-grade tumor does grow slowly, but it can turn into a high-grade tumor over time. Also, you may go directly to a high-grade tumor. So it's not always that a low-grade tumor starts as a low-grade and then becomes a high-grade. A high-grade tumor can start just from a no tumor to high-grade tumor.
So as Dr. Stockham said, we often think about primary or secondary tumors of the central nervous system. And brain metastases actually pertains to the secondary. So what that means is that brain metastases are cancers that are in the brain, but they didn't necessarily start in the brain. So just about any cancer, breast cancer, lung cancer, melanoma, any of the cancers can spread up to the brain. They usually do that by going through the blood. So the blood is circulating to the brain at all times. And so cancer cells may circulate in that blood. And for reasons we don't quite know, one of those cancer cells may stop in the brain and cause a tumor. So we call that secondary, kind of to distinguish it from those that are primary and start in the brain. Brain metastases are quite common because there are many patients with cancer, and in this day and age with lots of people on many drug therapies that will have patients living with cancer for a long time, brain metastases are often an issue for patients that cause neurological problems. This is where a lot of radiation oncologists, such as all of us on the panel, get involved with patients to be able to treat these brain metastases to prevent neurological symptoms and overall to control them. Sometimes too, cancers will go to the lining of the brain called the dura or the leptomeninges. And so those are also areas where we can use radiation to stop growth and to make symptoms better and to stop growth in this certain area.
So some of the most common types of primary brain tumors are actually the ones that were mentioned before that often grow on the lining of the brain or along the dura, and that's actually the meningiomas. After that, actually, you can have other primary brain tumors that are malignant, that are gliomas. And so of the gliomas, the ones that have the most aggressive behavior are called glioblastoma. Among the most common types of secondary types of brain tumors are patients who unfortunately have metastatic disease from the lung or from melanoma or from breast cancer.
Tumors, unfortunately, can also spread or originate in the spine. And the spine and the spinal cord are considered to be part of what we call the central nervous system, which would include the brain and the spinal cord, and extending all the way down to the lower portions of the back. And many types of different histologies of primary cancers that start outside of the central nervous system can frequently move to both the bones of the spine and the spinal cord itself and grow within the spinal canal. This can give different types of symptoms. This can lead to back pain in specific locations, which can feel very much like a strained back or a bruise along the spine. It also can lead to different neuro symptoms where you can have weakness in certain areas, tingling in certain areas, or numbness in areas that radiates to different parts of the body depending on where the tumor is located. And so if you do have these types of symptoms, it's important to discuss these with your physician, and often taking a look at the spine with different types of imaging techniques such as CT or MRI is an important part of doing any type of full workup once you receive a cancer diagnosis to make sure that there's no spots of cancer that have traveled to the spine and could be giving some symptoms or causing problems that will need to be addressed in the future. The most common types of histologies that go to the spine include some of the ones that we've mentioned that go to the brain as well. And these are breast, lung, prostate, and colorectal cancers. Now we'd like to move into talking about treatment of some of these types of tumors.
Dr. Arnett mentioned once we've diagnosed or identified a cancer or a malignant process, we know that the next step, we want to get started on treatment, and we want to help and care for people as they move through treatments. The first step includes establishing care with doctors. That oftentimes includes care from a number of different teams who work together. As Dr. Arnett mentioned, oftentimes we begin with imaging, which is a radiologist. So a radiologist looks at the pictures. And then there are oftentimes sampling of tumors. And that's where we look at the tumor under the microscope, and a pathologist looks at that. And so a pathologist and a radiologist are often involved in your care, but you may or may not ever meet a pathologist or a radiologist. And then oftentimes patients are referred to a combination of surgeons who help with performing surgery. And there are different types of surgeons. Your particular doctor and your regular doctor can help refer you to the most appropriate surgeon. And then there are also medical oncologists, and the medical oncologists, they deliver or administer medicines through the IV or sometimes with pills. And that's the chemotherapy. Also, they offer immunotherapy and other new and exciting medications, sometimes called small molecule inhibitors or immune checkpoint inhibitors. They oftentimes have long names that end with either IB or AB. And so the medical oncology team helps take care of the cancer head to toe with medicines. Radiation oncologists are radiation doctors who use x-rays, which are more powerful than a regular chest x-ray, to treat cancer. So instead of taking pictures with x-rays, we go ahead and we treat cancer with higher energy x-rays than a regular chest x-ray. But just like a regular chest x-ray, you can't see it, feel it, smell it, touch it. You wouldn't even know it's happening. And so the primary doctors that you'll meet in cancer care are surgeons, medical oncologists, and radiation oncologists, each of whom work together as well as have their own teams, oftentimes including nutritionists, social workers, nurses, advanced care providers like nurse practitioners or physician assistants, occupational and physical therapists. We also work with physicists, dosimetrists, and a whole host of people who are there to care for you and your loved ones. The types of treatments offered by each physician are the chemotherapy with the medical oncologist, the radiation by the radiation oncologist, and then the surgeon. Not all tumors require each type of treatment, the surgery, the chemotherapy, and the radiation therapy. Your team and your doctors will work with you. They oftentimes work very, very closely together to provide you the best care, which may include 1, 2, or all 3 types of treatments.
My patients often ask me exactly how radiation works and how exactly is it killing the tumor and not hurting their normal cells. I think this is a very important question and something that is challenging to understand, but I'll do my best to explain. radiation is generated either through a machine or through a radioactive source, or some other types of equipment that can generate the radiation, as opposed to it coming from a piece of material that is permanently radioactive. What the radiation does, no matter the source, is when it enters your tissues, it causes damage to the DNA and sometimes the proteins as well within the cells. And this damage causes an injury that is ultimately enough to kill the cell. Sometimes it can kill it very quickly, and other times it can kill it slowly. And so that's sometimes what we're referring to when people say that radiation will continue to work for a long time, is that some cells are killed right away, others are given an injury that over the course of several weeks will lead to the death of the cell. And then it will be processed by the body and either turn into scar tissue or some other type of tissue that is managed depending on where that disease is located and what organ the disease is located within. Overall, the way that it works radiation does indeed cause side effects and damage to tissues that are outside the area of the tumor, but we deliver the radiation in such a way that we concentrate it primarily where the tumor is, so that the high level of damage occurs in and around the tumor and the target that we're aiming for, and only a small amount of radiation is given to tissues around it. And by giving it in a strategic manner, either over the course of many, many days with breaks between treatment when as needed, or by calculating the dose in a specific way that's related to the tumor that you are trying to injure versus the tissues that are around it, we can set it up so that we give the tumor the best chance of dying, and we give the tissues around it the best chance of being able to recover and heal and have the minimum amount of side effects possible from the radiation treatment.
So for tumors of the brain, there are a variety of them. And for this reason, we always encourage patients to talk with their multidisciplinary team about whether or not they require radiation therapy. But to clarify, though, not all tumors will require radiation therapy. There are, for example, tumors that are more benign and slower growing, like some of the meningiomas that we'll just observe. There are also other benign like tumors like acoustic neuromas or vestibular schwannomas that will just be observed. And then there are also some types of tumors that after surgery will no longer need additional radiation therapy. And that can include some of the ones I mentioned above, but also sometimes some of those lower grade gliomas of the brain that we had discussed earlier. So it's just important to discuss it with your multidisciplinary team. In terms of radiosurgery specifically, radiosurgery doesn't involve any surgery, unlike the name sounds. It's actually our description for such a focused, precise form of radiation therapy that we like to think of it like a surgery. And what we're able to do is target those cancer cells very precisely with high doses of radiation therapy to kill those cancer cells. And by definition, this is something that is done in one session for radiosurgery. But having said that, though, a lot of people will refer to stereotactic radiation therapy, which is also a very focused form of radiation therapy that's also delivered in the brain. And that can be done in 1 to 5 with a similar concept of being able to focus in very precisely just to the tumor and cancer cells and spare a lot of the normal brain.
So what is the difference between focused and whole brain radiation? As radiation oncologists, we can determine based on what type of tumor it is, where we should focus the radiation. So should we focus it really quite precisely on just the tumor, like we do with radiosurgery that Dr. Yeboah just described? Should we focus it on the whole brain and even in the spinal cord, which we do for some tumors such as medulloblastoma that will go throughout the whole brain and spinal cord area? So it really depends on your type of tumor, and exactly what surgery you had and exactly what chemotherapy. And so this is where that multidisciplinary team of lots of different doctors would come together to talk about it. So we have many different techniques. So my job as a radiation oncologist is to decide where we should treat, but also how we should treat. And in our field, we have lots of different technology, which makes it so that we can be very specific. So you'll hear a lot of different names because there are a lot of different machines, but really all of it is radiation and all of it kills cancer cells or tumor cells like Dr. Arnett described. So what's the difference between protons and photons, for example? So most radiation is photon or X-ray radiation. So it's a very high energy X-ray. And just as if you got a chest X-ray, it turns on and off. And if you think about a chest X-ray, it goes in and it keeps going. Protons are actually a little bit different. They are a heavy particle. So they travel within the body and then they stop where we want them to stop based on their energy. So they're sort of like radiation with brakes. It doesn't make any difference in terms of how it's treating the cancer or the tumor, but it does sort of stop in a different way so we can make a different plan. So protons are for some specialized tumors. Protons are not available everywhere and they're not for every patient, but these are the types of different techniques that your doctor will think about in determining what type of treatment you need.
There are indeed a decent number of side effects that can happen that are associated with radiation. This truly depends on the area of the body that's being targeted, and also on it does have quite a bit of variability from person to person and the site of the brain that's being targeted with radiation. Most people do experience some significant amount of fatigue during their radiation treatment. That's probably one of the biggest complaints that I get when treating my patients, that when the brain is radiated, people are very tired. And I usually counsel people to don't push themselves past what they can tolerate, expect to take naps, just try to retain a healthy level of activity, but allow yourself that time to heal. We also can have anything from skin irritation, redness. If we're targeting the whole brain, most of the time we do see that the entire amount, most of the hair is lost at that point, and there can be some scalp irritation. Beyond that, when we do some of more of the focused brain radiation treatments, actually, you may not lose the majority of your hair, and there may only be small patches, if any, hair that comes out. So it can be I know that it's a question I'm very commonly asked, and unfortunately, I have to say most of the time, it's really going to depend on your body and your hair and exactly how the radiation beam is arranged to target the tumors exactly where they're located in your brain. There can be some more severe side effects, such as severe nausea and vomiting, seizures, new neurologic symptoms, and these are all very individualized and related to where the tumor is, how it responds to radiation, and any potential injury that had happened to the brain prior to moving into radiation as well. And so this is definitely a key thing to talk to your radiation oncologist about, and understand that we're with you every step of the way throughout treatment, every week, working with you to help manage the symptoms as they show up and counsel you and help keep you as healthy as we can while we move through the radiation treatments and address the symptoms as they come up.
I can take this. One of the questions, how do we know that the treatment is working? So generally, we will do an MRI or imaging, such as what you see up here on the screen, after treatment is all done. For most tumors that we treat, we don't necessarily look during treatment because it probably won't look any different, and you need to give the whole, often several week treatment to really see a difference. And then it's really following the MRI, because some tumors will respond and get smaller, many will stay the same, and some, even after radiation, will look more inflamed because of the radiation itself. And all of that is generally okay. Really what it is following afterwards to see and make sure that that tumor isn't growing and causing problems. what treatment options are available if the cancer returns, it really depends on your type of cancer. And that's where we work really closely with our medical oncology colleagues, with our surgery colleagues. It really depends on how it comes back, where it comes back. And there was a question from the audience about, it says, my breast cancer metastasized to my brain, even though I received radiation for my breast cancer, can I still receive radiation for my metastases? And in general, that answer is yes. So radiation can be used multiple times, especially if it's in different areas. So if you treat the breast with radiation, then there is no problem with treating the brain because the brain hasn't had radiation before. But even if you get radiation in the brain, we used to say you just get it once and you're done, but actually there's been a lot of series and retrospective series and clinical trials that have shown us that we can come back and give more radiation in certain situations. That depends on how large the tumor is when it comes back. It depends on what you got before. It depends on the time that you've had since it. So there are a lot of things that go into it, but you can have radiation more than once in many situations.
And I saw also in the chat an excellent question about looking for clinical trials. And I think that's very important when we think about the management of brain and spine tumors and for cancer patients. I think one of the most comprehensive websites for being able to identify clinical trials is a website called clinicaltrials.gov. And that provides detailed information on several trials open throughout the country. But oftentimes be able to get information that helps you best digest that information and understand it. It's ideal to go through your multidisciplinary teams just so that they can best explain to you what you're most likely to be a candidate for. There are also patient advocacy or patient navigation groups that can help for your particular type of tumor when you are looking through different clinical trials. But I definitely think that clinical trials are a appropriate avenue for a lot of patients to at least look into.
There's a question on, will I experience brain damage from my brain treatment? The answer depends greatly on how the radiation is done, if this is for a primary tumor or a secondary tumor, but the doctors are well versed and they're very experienced with finding the right amount of radiation and the right way of delivering that radiation to minimize that risk. So in general, it's extremely low. We have lots of experience in research around the amount of radiation and the number of treatments and the amount of radiation per treatment that's given. And so I would, in general, give reassurance that that risk is really very low. We're very careful, we're very cautious, and we take a lot of aspects of the treatment into consideration. All of the areas nearby the areas that we're treating, and whether you're having additional therapy at the same time with a medical oncologist. And so my answer would be a lot of reassurance with that risk being very low.
And I would like to, we also had a question come in from the audience asking if if radiation to the spine would cause you to be paralyzed in any way. And I would like to echo the same statements that were made by Dr. Stockham. We, above all with radiation, we want to be safe. We want to be safe for your spine, safe for the tissues around it. We arrange the radiation beams and the distribution of the dose in such a way that we are as safe as we can be to the spinal cord, but at the same time, effectively treating the disease that could be in the bones or near the cord. And that will sometimes affect the choice of treatment that we choose to utilize when managing cancers within the spine. It is something that's specialized and needs to be handled with care, but that's what we do. We keep things safe for you, and we always keep your best interest in mind when we're designing our radiation plans. And we can open up to any additional questions from the audience, either related to brain and spine cancers or COVID-19 as well, which is something that we've been commonly asked about. At least I'm sure all of us have in our clinics recently in regards to the vaccine and whether or not it is safe. Dr. Hollis, would you like to speak a bit about our opinions on the vaccine for our patients?
Yes, so we have been encouraging our patients to undergo the vaccine if when it's available. The vaccines may be administered to people who do have cancer, such as and under medical conditions, provided that they have not had a severe or immediate allergic reaction in the past to ingredients in the vaccines. And really, it's important to know that the mRNA COVID-19 vaccines, which were the first two vaccines to come out, and there was a lot of discussion about them because it's was a different technology than had been used for some other vaccines. They do not include any live virus or any virus, and so there was really no risk of contracting infection from the vaccine. Thus, we have encouraged all of our patients to undergo the vaccine. I have talked to my patients that when they're undergoing radiation therapy and getting the vaccine, there may be a day where they might have some symptoms from the vaccine, and just to work with your radiation oncologist. It really should not interfere with the treatment that you're getting.
Okay, well, thank you all very much for joining us today. We hope that this has been informative. We, of course, again, direct you to our website, RTAnswers.org. If you have any additional questions or would like any information, you're also welcome to reach out to us personally through our institutions. At least I'm more than happy to be of any help that I can be whenever needed, so that we can do our best to educate and support our patients through their treatment processes. And thank you again to our panelists for taking the time to be here today for this important presentation.